welcome Dr. Genevieve Buser from the Oregon Public Health Division. Dr. Buser?
Good morning. Thanks for inviting me to present on some of the work that we've done here in Oregon around our CDI initiative and give you some ideas about how working on C. diff, as you've seen with Rochelle's presentation, can be your foot in the door for working on other issues around antibiotic stewardship. And I'll speak a little bit more specifically to interfacility communication as well. So I'm one of the public health physicians here at the Acute and Communicable Diseases, and I work primarily with the healthcare-associated infections. So the objectives of my talk will be to describe the initiative where we worked on CDI, work here in Oregon, and interventions around interfacility transfer communication and partnering with environmental hygiene. And also specifically want to tell you a little bit how we had to adapt to real-world challenges here with our funding at the state. So initially when we wrote our grant for the Epidemiology and Laboratory Capacity Program, which is the grant that we use at the state HAI program in order to fund the work that we do for HAI here, we don't receive any state funding, so it's all grant-driven. So we had applied for that, and we had this great dream team idea to lead the CDI collaborative while working with our Oregon Patient Safety Commission, which is a nonprofit safety commission here in Oregon that's very active and very helpful with all our healthcare facilities. And so we'd hope to have an administrative support, a project lead, and work with an infection control nurse at Oregon Patient Safety, in addition to myself as a public health physician at the state. And we wanted to create educational series and recruit several hospitals, each with 2 or 3 long-term care facilities, so that we could look at interfacility transfer communication. We wanted to be able to go out, so we could visit them personally and get them to sign up for NHSN, which is the National Health Safety Network surveillance system. And NHSN is, as you probably know, is what's used now for hospitals to report HAI. There are not very many long-term care facilities on that, and CDC had wanted to make a bigger push for that. That's what we had hoped to do, but unfortunately, just the reality of the funding that we received didn't allow for all the staffing. So we had to sort of rethink what the hope would be to do with this. And of course, that's also when Ebola came along, so I was also called into assist at the state level. But I think actually, thinking back on this, that Ebola itself has been probably, and maybe you guys have seen this as well in your facilities, the best advocate for improving all these things that we're working on, whether it's interfacility transfer communication of infectious diseases, hand hygiene, and correct use of personal protective equipment. I think probably Ebola has been more than 100 CDI outbreaks could do in some sense of it, at least here in Oregon, as far as raising the general awareness of the importance of infection control and early identification. And it also helps bring together a lot of different partners that that we wanted to use for infection control. So with that in mind, I had to go ahead and think about how to redo the project. And so I turned to other alternatives, and I think these are some interesting examples that you could maybe think about around your own state if you needed to do something like that. So first of all, I looked at our emerging infections program, and this may exist in some of your states, but they do a lot of grant-based work with the CDC, and we have one that does population-based Clostridium difficile surveillance. And we have, in that county where that's done, we have very good connections with the hospital and the skilled nursing facility there. And so we were able to recruit them to work on some of those issues of interfacility transfer and also antibiotic stewardship. I also turned to look for the Oregon Patient Safety Commission because they've been doing some great work in a related field. So they just had completed a catheter-associated urinary tract infection collaborative. That's called the CUSP collaborative for short. And as part of that collaborative, they have recruited long-term care facilities here in Oregon to sign up and submit data to NHSN for urinary tract infections. And I was able to, with their assistance, was able to then, after they finished that collaborative, then recruit from that group of facilities who's already somewhat familiar with NHSN and get them using the Clostridium difficile lab ID event submission. So again, trying to kind of build off of something that was already going and try to move that forward towards CDI work. And then also, we have just a handful of, we of course have sort of, our independently owned long-term care facilities, but we also have a few large long-term care networks. And I was able to reach out to their corporate folks and get them involved and excited about this and have them suggest some facilities that would be interested in in working with this and try to just to make the recruitment a little bit more efficient and we'll get some buy-in across the network. So, and then because it was just going to be me working on this project, I had to change from being this kind of full-blown collaborative to more of a mixed method type of work. And so I was wanted to focus on the baseline assessments, so to be able to provide, to use there's a Center for Disease Control tool that we can share at the end, but that helps with these baseline assessments in the facilities, and then really work for facility-specific goals and report on the reports that they could work on improving. I worked on health education both for the initiative and also going forward be very important, so worked on that. And then tried to build up connection with hospitals and skilled nursing facilities who are in the same regional area to work on interfacility transfer communication. The environmental hygiene as well, sharing things that had worked from one hospital to another. For example, Rochelle mentioned that the bleach wipes had worked very well. We had a couple of one of our hospitals have some great success with using Sporcidal, and so sharing that with other folks as well. And then finally, to create a website that could, so that the work we've done can be shared more widely. So overall, I was able to enroll 3 hospitals and 8 skilled nursing facilities, and we focused on 5 areas of work. And those were first around surveillance. Of course, what you count is important, and trying to get them enrolled in the National Health Safety Network, which is, if you're not familiar with it, it's a free way to track Clostridium difficile and many other HAIs in your facility. And you can also then analyze the data and receive the data back. We focused on best practices around CDI, many of which Rochelle touched upon. We tried to build those partnering connections with the environmental hygiene within each facility, because those sometimes that can be somewhat siloed, so trying to work on that together. Antibiotic stewardship, thinking about the basics, and interfacility transfer communication. And I'll get into these a little bit more in each one. So to begin with the first, so I mentioned we did these SafeLine assessments, and I think I really tried to call them consultations, because assessment or anything that's assessed or survey, when you go into a long-term care facility, it's immediately that's interpreted as being a regulatory survey, a regulatory assessment. So that comes with fees and penalties and fines and tags and things like that. So based upon the work that I'd done with Ebola, which had some of the same reaction, we really tried to talk about these as consultations to frame them correctly for what they were, as a way to assess and to learn. So here are some screenshots from the assessment tool that was piloted for this initiative at the different sites around the U.S. that received grant money, and it goes through the main domains of preventing Clostridium difficile, or really any other infection control issue around what's your capacity, your training, and then getting into more specific things like antibiotic stewardship, environmental hygiene, how you're mixing things. They ask about testing, when do you test, how do you test, what type of test are you using, etc. There's a component that also interviews the pharmacy and the laboratory to understand those components as well. And all of these were shared back, or summarized back to the facility, so they could have that to discuss with their administrators, along with a letter that was on state letterhead saying, hey, these are the things, thank you for your collaboration on this, and here are some of the findings that we found, and that you may want to work on these more. And the directors of nursing really appreciated this, because in this way they could share this back to their administrator and actually come up with some concrete action plans for their facility. So that was those baseline assessments. The other piece I mentioned before was looking at interfacility transfer evaluation, and use this initiative to look at that. So to give you some background about why this is important in Oregon, in January of 2014, we passed a rule where healthcare facilities are required to communicate in a clear written fashion if the patient has a current infection or a history of a multi-drug resistant organism, or C. difficile, or has another infectious disease that could be transmissible. So has a vomiting and diarrhea, or norovirus, or scabies, or MDR-TB, but that this information be very clearly written on and available so that healthcare providers, including medical transport along the way, can see this and can appropriately protect themselves. And in addition, so that the receiving facility can appropriately room the patient, et cetera, in order to prevent early transmission of infectious diseases at the arrival facility. So we had put this rule into place on January 24th and hadn't had a plan, and wanted to evaluate how this was working. And we had to do surveys and such like that. But basically what I was able to do with this CDI initiative is because we were looking at Clostridium difficile, we could look and see, okay, how, for cases of known Clostridium difficile, is that being correctly communicated to the receiving facility? Or likewise, if there's a new diagnosis within the first 3 days, being present on admission, is that being communicated back to the facility that just sent them, and it was likely where they acquired it. So that was able to kind of take this in collaborative that couldn't quite be a full collaborative, but then still use it to run something and to hopefully help the process of improving interfacility communication. I was able to create a database and do chart reviews, and so that's still ongoing right now. So, so I guess right now we have a first polling question for the talk, and to ask if in your facility are interfacility transfer forms used. So please go ahead and mark your. And I wanted to say, just for clarification, these forms could either be separate written forms, or they could be the same information about multi-drug resistant organisms, colonization, infection, or other infectious diseases that are in an electronic form, like an after-visit summary. So that counts as well. And I think, who's on the line, I believe the state of Utah has a similar rule as we do. Great, thank you very much. So it looks about 30% have an interfacility transfer form when they're discharging to another facility, and they use that consistently. Another 20% intermittently, but not consistently. About 9% use only with discharges that have a multi-drug resistant organism diagnosis, and then about 28% don't have one as any communication in place, either a form or e-form. And there are some great examples, and again, that information can be shared as well. We have them on our webpage. I know Utah does as well. And then, and this is the second polling question. In your facility, or does your facility provide forms or a copy of electronic transfer forms for medevac transport vehicles? And again, this is to ask about how this information is communicated to medical transport folks along the way. And I think some of the challenges with this is that, this information, talking anecdotally and doing the chart reviews, may be hidden in the physician's note, or maybe in, like a social worker or discharge manager's note, but is not prominent or easily findable, either for the transport or the receiving facility. And that's what we want to try to improve, and that it be up there along the same lines as allergies and current diagnoses. So looks like about 60% said yes, they do provide something for their transport vehicle. Great, thank you. So we'll go on to the next piece here. So that was sort of the work around the that we're doing with interfacility transfer. And then the other piece, when we were did these assessments, SafeLine assessments for the hospital, one in particular was having some problems with 2 of their units that were high-risk units. And so we worked with them we're working with them to help identify what the prevalence on admission for these 2 units with high CDI rates. And these are units that are otherwise closed units, they're transplant oncology. And so trying to understand how many folks are coming into those units with C. diff, and should something be done differently, because despite a lot of effort, the rates remained high there. We also want to look at transmission events that may be occurring in this group, since it's a nice defined population, and we'll be looking both at within the hospital, but potentially also later on for in other long-term care facilities. And so we hope, again, that, and as part of this as well, not only the prevalence of patients, but we're going to be looking at the environmental burden and seeing how that can be affected by perhaps adding something new, other targeted interventions like a new sporicidal, et cetera. So this, as you've seen from these examples, it's really, the reality was without being able to create the full collaborative, we had to be creative on how to find collaboration through other ways. And Acumentra has been very helpful with that. We've been able to work with them on using the baseline tool, and we hope to continue to partner with them going forward on more recruitment of long-term care facilities to NHSN. We've been able to collaborate with another grant-funded program here that we have at the state called AWARE, and that works on raising awareness around antibiotic stewardship and judicious use in the outpatient setting. So we've done some webinars with them and are hoping to create some new grant projects around antibiotic stewardship in long-term care facilities, really specifically focused on asymptomatic bacteria and the overtreatment of that. If you go into a long-term care facility and you ask what the most common reason for antibiotics is, it's UTI. And many of those UTIs are not truly symptomatic urinary tract infections, but rather colonization. And of course, that antibiotic exposure leads to C. diff. So we're trying to collaborate with those folks who have some expertise in education and around outpatient antibiotic stewardship to help us with that long-term care piece. We hope to continue to work also with the Oregon Patient Safety Commission. They've been a great partner, and they're doing a lot of our ICAR visits, which, if you're not familiar, those are the infection control assessment and response visits that are also grant funded through the CDC to try to improve infection control capacity across the healthcare spectrum. So really neat opportunity. And we're also trying to work more with our Office of Licensing and Regulatory Oversight. And those are the regulatory folks, but they do a lot of education and have a lot of great contacts in the long-term care world. And so trying to support them and work with them on improving rules and education to facilitate better infection control. The resources that I was able to create in collaboration with the folks that we're working with in the hospitals and the healthcare facilities and Oregon Patient Safety and CDC and just really anybody I could work with, we were able to create a CDI learning session and a toolkit, and specifically some certified nursing assistant, that's the CNA education. In my talks and visits at the long-term care facilities, this is a really huge need. Those are truly the frontline providers, and it's truly them who need to be supported both in education and resources to do the right thing every time that they are working with a resident who either has a multi-drug resistant organism or CDI. Resources will make available these assessment tools that were created as part of this initiative to be available more broadly so that facilities could use this as a quality improvement piece and have some guidance around that. And then finally, how to navigate from the National Health Safety Network education or enrollment process, which can be a real challenge for long-term care facilities. So we hope to, with the success that we've had so far, we hope to be able to write for some continuation of this work so that we can continue to work with Acumentra and their work with long-term care facilities around CDI reporting and to include our interfacility transfer communication of infectious diseases in the grants going forward. If anyone's been paying attention to Medicare or CMS, they've been talking a lot about care transitions. Most of that has to do with more, non-infectious pieces, but we really keep lobbying and trying to say that, communication of infectious diseases is part of those key care transition variables, and that is as important as communicating the correct medication, reconciliation, et cetera, because it has great impact on transmission. And as I mentioned before, there's some grant work that are being done around the country with the Ebola Part B grant, which is the ICAR, the Infection Control Assessment and Response piece. And I think most every state has something going on with that. So this would be a great opportunity to get the word out of these consultations and make them really a reality. CDI is present everywhere. It's something that every facility can work on, and it gives them a real life challenge to work on and to apply what's being seen on these consultations and observations of infection control practice. And then finally, I think hopefully with the grant and going forward, we'll be able to get some more assistance to be able to develop this program and make it more robust. So thank you for any, happy to take any questions at this time to discuss sort of what we did with the initiative or asking or describe in more detail what we've been up to. Thanks.
Thank you, Dr. Buser. And Azure, if you could open up the phone lines, please, for questions.
Ladies and gentlemen, at this time, if you have a question, please press the number 1 key on your touch-tone telephone. Again, ladies and gentlemen, if you have a question, please press the number 1 key on your touch-tone telephone.
This is Genevieve. I was going to draw your attention to the chat box. Linda Egbert sent the Utah transfer form there, and there's a link in that as well. So,
thank you. And Jen, there's a question from the chat from the last presentation, but I thought you might be able to answer it. Is should they be doing C. diff screening in long-term care?
From the previous one. Okay, so 2 things. I just put up the website for healthoregon.org/HAI, which takes you to our main HAI webpage, and on that, on the left gutter, there'll be links for prevention and then interfacility transfer communication. As far as screening for long-term care facilities, I think it's somewhat of the same issue as for the hospital. We're not clear at this moment what it means to be an asymptomatic carrier of treating them may actually provoke symptomatic diarrhea. So part of the project that we're doing with the hospital and looking at prevalence is to get an idea of the burden that's coming in, but it will not lead to any more treatment of those asymptomatic folks. We're going to identify them and then follow them over time and see, which percentage do become symptomatic, or if there's any events of transmission that are linked to them, if that's possible. But it may be something if you have a facility with a very high healthcare onset incidence, as with these 2 units, it may be worthwhile doing that for a defined period to understand what your true, what's coming in the door. But it needs to have clear outcomes of how you're going to use that data. Is it because, you're trying to target a specific intervention? Is it to get a sense of what burden's coming through the door? How's that going to change your environmental cleaning or your contact precautions or certain things like that you're testing? When you know that 30% of your people coming in are carrying it in their stool, how's that going to change your preemptive contact precautions? So I think if you do that, you want to have clear outcomes that are set up ahead of time and what you'll do with that data. But it's not generally recommended.
Thank you.
We did that with a similar facility which is a rehab facility that was having a lot of hospital onset multi-drug resistant organisms, carbapenem resistant organisms, etc. And MRSA. They did set up do that screening on admission in order to see what was coming in their door and then what was being acquired internally. And sort of what they found was that, yes, there were some things coming in the door, but there was a lot of amplification within the healthcare facility, and thus infection control could, speak to the administrators and say, look, we can't just blame it on what we're getting from elsewhere. We need to look internally and really spend time and resources on improving that. So it was helpful in that instance to do that on admission prevalence screening for a defined period of time to see and to focus their efforts on internal. So there was a question about, a question: if the patient is colonized but not symptomatic, then do not treat, correct? That is correct. So if someone is just colonized and you treat them, and they're not having symptoms, and you treat them with flagyl, you may in fact provoke them having a symptomatic Clostridium difficile colitis. So currently there is no recommendation to treat those folks. And would probably want to be extra cautious on when you did start antibiotics because you know that they would carry it. But that's exactly why Rochelle, their team spent a lot of time on making sure you're testing truly symptomatic people because folks can carry it and not have a problem. So that can lead to confusion. So yeah. And I just see some of the comments coming through about the emphasis on transfer of information. And I think just a little bit more on that. We, for example, in Oregon, we have a low rate of carbapenem-resistant Enterobacter ACA. Most of ours are coming from other places where there are higher rates. And so having information is really key to our healthcare facilities in order to appropriately place those patients immediately on contact precautions and prevent it becoming an endemic problem here. So I'd like to see that happen more and to include not only infections but colonizations. And we typically ask for 1 year in the past because we know that the CRE particularly can be carried for many, many months.
Thank you.
That's pretty much all I have.
Are there any questions in the queue?
No, ma'am, there are no callers in queue.
Okay, thank you. Thank you so much, Dr. Buser, for your enlightening presentation.